morning, ladies and gentlemen. Airway management in the out-of-hospital setting. 10 minutes are extremely short time for this topic, but as always in emergency medicine, we have to be fast. First of all, probably the most important point for the airway management in the out-of-hospital setting: resuscitate before intubate. In 45% of the patients, we have to intubate in the emergency setting. We will see at least one severe complication. And the most frequent complication is cardiovascular instability or hemodynamic instability in nearly half the patients. 90% of these patients, we need a new vasopressor. In 14% of the patients, we see severe hypotension of less than 65 millimeters mercury. And in 14% of the patients, we need volume resuscitation with more than 50 milliliters per kilogram body weight. So if you decide to intubate a patient in the pre-hospital setting, have vasopressors at your fingertip and have a large bore IV line running. And we have to be aware that about 3% of the patients we intubate in an emergency setting will suffer a cardiac arrest. Again, the most frequent reasons are hypovolemic and hemodynamic instability, as well as hypoxemia. So this points out the importance of good pre-oxygenation, as well as vasopressors and fluid resuscitation during emergency intubation. And we will be able to resuscitate successfully only half of the patients who suffer a cardiac arrest during intubation. So this is really a high risk procedure. And this study also shows that the number of complications during emergency intubation correlates with the outcome of the patient. After adjusting for the disease severity, the odds ratio for mortality after with complications during emergency intubation is 1.52. The study also shows that the number of intubation attempts correlates with the probability of complications during intubation. So we have to do everything possible to improve our first pass success rate. The first pass success in patients with out-of-hospital cardiac arrest seems to correlate with the chance of good functional outcome after resuscitation. If we need only one attempt for successful intubation, the chance is 11%. If we need more than 4 or more intubation attempts, the chance of good functional outcome is only 2%. After adjusting for influence factors like sex, age, or the rate of bystander resuscitation, or the rate of witnessed cardiac arrest, time until arrival of emergency medical team, the adjusted odds ratio for good functional outcome decreases to 0.41 with each intubation attempt we need for successful intubation. If we talk about preparing our patient for out-of-hospital emergency intubation, we also have to talk about the dosing of rocuronium. This retrospective analysis from Canada showed that the first pass success is higher if we use a dosing of rocuronium of at least 1.4 milligrams per kilogram body weight. This is especially true if direct laryngoscopy is used. You see the chance of first pass success increases with higher doses of rocuronium. With video laryngoscopy, there seems to be no correlation between rocuronium dose and first pass success. If we talk about first pass success and video laryngoscopy, we have to talk about this study. This study shows very, very impressive that first pass success can be improved by using video laryngoscopy. Brown et al. Compared the first pass success with direct laryngoscopy with all these aids to improve our first pass success, like external laryngeal manipulation, use of bougie, use of a ramp position. And if we group all these attempts of direct laryngoscopy, we see a first pass success rate of 81%. If we just use simple video laryngoscopy without any aids, unaided video laryngoscopy, we see a first pass success of 91%. Video laryngoscopy can improve first pass success even in toddlers. The study from Australia showed a significantly higher first pass success of 93% with video laryngoscopy in toddlers compared to 88% with direct laryngoscopy, and only half the rate of severe complication in these little patients. Video laryngoscopy, of course, is especially helpful for our inexperienced users. We all know that from our daily clinical practice. This is quite trivial, but this study showed that it is even helpful for the very experienced users. It is a study from our HEM screws in Germany and the Armed Forces Hospital in Ulm. The HEMS doctors are only very experienced consultants in anesthesiology, and when using the video laryngoscopy, we see significantly less frequency of unfavorable glottic view compared to direct laryngoscopy. And the odds ratio for first pass success with a favorable glottic view was 12.6 times higher than with an unfavorable glottic view. Should we use a bougie for emergency intubation in the out-of-hospital setting? Data on the use of a bougie is a little bit conflicting at the moment. We have this prospective monocenter pre-post observational study from the Seattle Fire Department. In the pre-period, they evaluated first pass success over 18 months without the use of a bougie, then a training period of 3 months after introduction of the bougie, and then again post-evaluation for 1.5 years with the use of a bougie. And the study shows a significantly improved first pass success with the use of a bougie, and the advantage of the bougie use is especially pronounced in patients with a cormic Lehane view of 2, 3, or 4. And we see significantly less chance of suffering from hypoxia when a bougie is used in these patients. However, there's another study on bougie use that shows that first pass success is higher with a bougie, 95 compared to 86%, but the median attempt duration is significantly longer with a bougie use. This means these results are also shown in patients with out-of-hospital cardiac arrest. This is a secondary analysis from the PART trial. We can see that the time for successful intubation is significantly longer when a bougie is used compared to the non-bougie use. But the first pass success is significantly higher, 52% compared to 44% with the non-bougie use. What does this mean for the outcome of patients during CPR? The outcome of patients with the use of a bougie is only 3.6% hospital survival with a bougie use compared to 7.5% with when a bougie was not used. After adjusting for influenza infectis, we see a adjusted odds ratio for hospital survival of only 0.94 for the if a bougie is used. And last but not least, use of a stylet, a large multi-center RCT in 32 ICUs in emergency intubation. Results are quite impressive. The first pass success is significantly better when you use a tube with a stylet compared to a tube without a stylet. The complications observed during intubation are not significantly different between the both groups. So to sum it up, think that you have to resuscitate before you intubate, dose rocuronium high, optimize your first pass success. The best device to improve your first pass success is the video laryngoscopy for everyone, even for the experienced, as a primary device. Use a stylet, and the data on bougie are conflicting, but especially for the inexperienced user, I would prefer the use of a bougie. Thank you very much.